I'd like to thank Dr. Renjen and all of you present here. This topic actually is important because most management in major hospitals transgress the time limits which we have set for management. And the neurologists basically and the residents basically need to act as terminators for status. Status epilepticus is a profound condition in which the mechanisms for stopping seizures have failed. So the seizure persists and goes on repeatedly, producing an enduring condition where there are repeated seizures. It's not uncommon. We see one status in every emergency. It's about 10 to 40 per 100,000. And generalized convulsive status epilepticus is around 75% of all our cases of status are generalized convulsive, and about 25% would be the rest. The new update in status is a recent classification and recent definition of status epilepticus, which is done by the team of the International League headed by Eugen Trinka. Now this new definition basically states that we as neurologists need to be sensitive to two time points in the management of status, that is time point T1 and time point T2. So T1 is the time within which if we manage the status, there is going to be minimal or no damage to the neurons and long-term consequences. And T2 is the time beyond which if the status continues, there are going to be profound consequences as well as neuronal damage. That is going to be more or less permanent for that particular patient. Now, why are these T1 and T2 important? Now, previously we would say, when I was training in DM neurology, that half an hour is status. If you're convulsing for half an hour or you've had two seizures in between of which you're not conscious and it's 30 minutes, you have status. But the T1 is now reduced. The T1 is reduced because we know almost all generalized seizures, 98% of them, will stop within 2 minutes. So all generalized seizures must stop within 2 minutes. If it's a focal seizure with impaired consciousness, which was previously known as a complex partial seizure, 98% of them will stop within 10 minutes. So anything beyond that is going to be of significance, in that we do have 98% of the seizures, whether they're generalized, stopping within 2 minutes, and if they are focal with impaired awareness, they stop within 10 minutes. Hence, the T1 is now defined no more as a half an hour. The T1 is 5 minutes for a generalized tonic-clonic seizure, and beyond 5 minutes of these motor movements is the T1 set for the generalized tonic-clonic status epilepticus. Whereas the T2 for generalized tonic-clonic, where the convulsive movement continue, is less than 30 minutes. That is, beyond 30 minutes of continuous movements, you're going to have permanent damage. The T1 for status epilepticus with impaired consciousness without motor movements is 10 minutes, unlike 30 minutes which was before, or 1 hour which was before, and the T2 is between half an hour to 60 minutes. For absence status, the T1 is about 15 minutes. The T2 is not known because really it's not known and documented as to how much damage absence status is going to have if it continues for long. So no more is, we can be, complacent on the management of status. We have to act within 5 minutes, which really doesn't get well done in our setting in our country. Before we even go on to the classification, we must try to establish 4 axes in any patient with status. The axis 1 is the semiology. Is it a generalized convulsive? Is it focal convulsive? Is it a non-convulsive? It is a myoclonic status. Is it an absence status? Is it a non-convulsive status with obtunded sensorium? So basically you need to identify the semiology, which is the axis 1. The axis 2 is the EEG, particularly the status has crossed the time point of T2. The axis 3 is etiology because that has impending significance on the outcomes, and the axis 4 is to pay cognizance to the age because age also has prognostic markers. Again, I go back for the residents to read this article by Eugen Trinka, which is a landmark article which tells you this definition which I have just enumerated and also shows the classification in a tabulated form, and probably this should be there in all your ICUs where you have clearly demarcated the axis 1 of the classification, which is a convulsive status with prominent motor symptoms, whether it's generalized convulsive, whether it's myoclonic, whether it's focal motor, whether it's tonic status, and whether it's a hyperkinetic status epilepticus. And without motor manifestations, which is the non-convulsive status epilepticus, which can again be divided into two parts, with coma and without coma, and can again be divided into generalized and focal and aphasic status, so you must be familiar with this classification so that you're not going to miss and you're going to identify. Hence, after you've, really thought that your patient could be having status, you need to identify where in the time point are you seeing this patient with status. Are you seeing in the first phase, which is the early phase or the pre-monitory phase, where you're within the 5-minute or 10-minute window? Are you seeing this patient when he's crossed that 5 or 10 minutes window and is within the 30-minute window of the T2 of the generalized convulsive status epilepticus? Or are you seeing this patient in your emergency after he is referred to you, being on Midazolam, being given Midazolam, being given diazepam, and still convulsing after giving phenytoin? So there it becomes refractory status epilepticus. So they fail 2 anti-seizure drugs, whether one of them is a benzodiazepine and the other is an anticonvulsant. So when they fail that, they enter the refractory status epilepticus definition, and usually it's in about an hour by then. Or is it beyond 1 hour where you have given all the agents for managing status and the status is still continuing? There it becomes super refractory status epilepticus, that is beyond 24 hours, where the patient is going on convulsing. And most of the patients we see in AIIMS come in the super refractory status epilepticus to us because they are convulsing despite having transgressed all these stages. So super refractory status is also that status where you have started anesthetic agents, and when you attempt to taper the anesthetic agent, there is a resurgence of seizures. So super refractory is not just beyond 24 hours, it's also re-emergence of seizures once you start tapering your anesthetic agents. Why is it important to categorize patients? Because status carries a high mortality of about 20%, and a short-term fatality for refractory status is as high as 39 to 40%. So you're dealing with a mortality range of 20 to 40%. And the mortality is 3 times higher than for non-refractory status epilepticus. So you have to be very cognizant of the fact that refractory status epilepticus carries a high mortality. Also the fact that if you have status, there is a 3 times higher risk of having subsequent seizures in your life. That is, if you've had managed status in your ICU and this patient goes home, this patient is more likely to come back to you with seizures or status, 3 times higher than that of acute symptomatic seizures. And of course, patients who are refractory in status are less likely to touch the normal baseline which they were before the status. That is, they are no more going to be the same individual. So the chance that the person returns to being the same individual after refractory status epilepticus is as low as 20%. And that for a non-refractory status epilepticus, there is a 60% chance that that person is going to return back to his normalcy as he was prior to the status. The etiology, I said, is very important. In our country, a very important etiology is withholding the anti-epileptic drugs or going to an alternate practitioner and not taking your prescribed anticonvulsants or not being adherent to anticonvulsants. That's an important cause of status. Apart from that, in our country, we see a lot of infections causing status, meningitis, encephalitis, autoimmune encephalitis, strokes, acute ischemic events, bleeds. Apart from that, anoxic damage, toxins, so alcohol, all these are, common causes, electrolyte imbalance, hypoglycemia, etc. It's important to know the etiology, and I keep telling you this, that if you do not find out the cause, you will not be able to prognosticate the relative standing outside your corridors. As you can see it, if the patient's etiology is going to be hypoxia or anoxia, there's going to be a very high mortality to the status, as much as 70%. So you need to know the cause, and the frequency of status is also going to be high if the etiology is stroke and low anticonvulsant levels. Now, the time window for clinicians is important, as I told you, within 1 hour, within 30 minutes, because the body and the brain within that 1 hour, within that 30 minutes, tries to compensate for the recurrent seizures by increasing the cerebral blood flow, by regulating the cerebral autonomic activity. So within that, 30 minutes is the green phase of status. But beyond that, the phase 2 of the status is where there is a failure of all cerebral autoregulation, the cerebral blood flow falls, there's increased intracranial pressure, and that's where you've entered the high mortality zone of status, which is the red zone, and you really don't want to end up there. It makes sense biologically also because there is an irreversible cascade of events or domino effect which starts as the time progresses. Within few milliseconds of the status, there is an active ion channel opening and closing and protein phosphorylation. Within seconds to minutes of the status, the cascade downrolls into decreased GABA and internalization of the GABA receptors. So no more are your GABAergic drugs going to be effective. You have to use drugs which have alternate mechanisms of action. Within hours of the status, you have neuropeptide expression and increased excitatory substance P. And of course, decreased inhibitory substance. And stage 4 of the status is when it's gone on for days and weeks, where there's a permanent gene alteration and DNA methylation changes and changes in the microRNA. So to sum up the first part of my talk, status is a condition in which the brain is on fire and time is brain. And of course, the neurologist has to knock out this particular condition. So as soon as you receive this patient, you will answer in the exam saying you are going to do the ABCs, you're going to establish your line, you're going to collect the blood for the blood sugars, you're going to do monitor the vitals, you're going to do all the labs. If the patient while you're starting your anticonvulsants, you're going to investigate by doing an imaging, you're going to do a lumbar puncture, toxicology, all that will go on. Subsequently, when the patient is in the ward and hopefully you've started the treatment, which I'll dwell on in a little while, the residents must perform the EMC scoring, and this scoring is of immense value because the relatives don't understand the seriousness of the condition. I've had 2 legal cases to opine on, both coming in from private hospitals where the patient died and the parents did not understand the significance of status, and they sued the doctor, and the doctor was completely innocent because the EMC scores were very high. Unfortunately, the doctor had not documented the EMC scores in the file, and they had to be calculated by the team which was opining on the case. So really, all residents must do the EMC score. It's the most important prognostic score in status. You have to look into the etiology, and there's a scoring given to the etiology. You have to look at the comorbidity. There's a scoring for that comorbidity. You have to look at the age and the EEG. Once you've done the scoring, any scoring which is above 4 carries a bad prognosis. So please do the score in all your files. Apart from that, you are going to be managing, you're going to be trying to control the convulsions. This is the chart which my residents follow. This is with them. This is there in our ICU. This is there in our epilepsy monitoring unit. Please have a ready chart for your residents. Do not expect the residents to fumble for the doses when they're confounded with the status. Either you have to have a resident who has all these doses in their head. Having the chart there on their mobile phones or on the notice board in the emergency or in the ICU is important because the doses are important. Very often I see suboptimal doses of all anticonvulsants, and the status has moved on to refractory. So one of the common causes of the status moving on to refractory status is suboptimal low dosing of the anticonvulsants. Please load first with Midazolam. This is what we use. Go for the higher doses first. Do not start with the lower doses. So you start with the lower dose, you are going to have to build up the dose, you're going to waste time. If you start with the highest dose, if the BP falls, you can always move on to the lower dose. So 0.2 milligram per kg is the bolus, and then you go on to 0.5 milligram per kg per hour in an infusion if you have to use it later. But simultaneously, along with the Midazolam, you must start your phenytoin or phosphenitoin, 20 milligram per kg, phenytoin at the rate of 50 milligram per minute, phosphenitoin at the rate of 150 milligram per minute, whichever you have. Status still not controlled, don't wait for your ICU. The ICU may not be available. Load with valproate. The loading dose of valproate is 40 milligram per kg. Status still not controlled, your ICU is not ready, you don't have a bed, you don't have intubation ready, load with levetiracetam, the dose of which is again 40 to 60 milligram per kg. The rates are given there. The rate for valproate is around 3 to 6 milligram per kg per minute. The rate for levetiracetam is again 5 milligram per kg per minute. So know the rates, the resident must know the rate so that they don't over-infuse or under-infuse. Sometimes you see the bottle hanging there going on for 3 hours. That's again converting it to refractory status. So you've done that, you've managed well, you've given Midazolam, you've given the first-line drugs. It's important that you try to stop the status with the first drug, because there's data, immense amount of data, that the response to the first drug is the best. So if you can knock out the status with the first anticonvulsant, then the chance of them going on to refractory status is less. So please try to control with the maximum dose of the first drug by itself. This is also shown in this graph, which has been researched by Jaideep Kapoor, where he showed that the dose of diazepam was exponentially higher the longer the time you allowed the status to continue. So you really want to knock out with the high doses right in the beginning. This is just to highlight that I prefer Midazolam, and the reason I prefer Midazolam is, of course, there is a Cochrane review between lorazepam and diazepam which clearly shows lorazepam is better, but if you look at lorazepam, it contains propylene glycol, and it also causes significant accumulation in the fat, as compared to Midazolam, which is water soluble and its action is short duration. So if you're ending up in a patient with hypotension, you're less likely to have problems with Midazolam. And Midazolam can also be given by alternate routes. If your nurse is not finding the IV line and the patient is actively convulsing, please ask them to give IM Midazolam, 5 milligram to 10 milligram, 10 milligram is adults, 5 milligram is children. So you can give IM Midazolam because it's eminently water soluble and short acting, but you have to top up with the other anticonvulsants.
What I can continue. This is why I am telling you important is because 2 episodes of having quadriparesis referred to me from Jaipur Golden to BLK with a diagnosis of AIDP that it might worsen. So we gave IVIG, he improved. Second time also same thing. This time he came before even our giving anything, he improved. Then I sat with the patient, took the history. Most of the time they give you no time actually, but you have to give time. And this time I thought it is periodic paralysis. Why he is improving so fast? Conductions are borderline. If you will see, Master Lakshya Diwan presented with clinical indication of weakness and elevated CPK level. Mild CPK level you can get high in GBS also when there is lot of pain. His chest X-ray was suggestive of prominent bronchovascular marking, and CV was suggestive of bilateral motor axonal demyelinating neuropathy. So there was decrease in amplitude and the velocities were into 40 and 45 range. So this was the history we gave, and we got a genetic study done. So genetic study people did not get the history of periodic paralysis, so they reported that it is not a significant mutation, but it is a Alexander-Tavy syndrome. So this also I am presenting as my last patient, which actually is a periodic paralysis with cardiac abnormalities, with dysmorphism and recurrent weakness. So that ends my presentation. Thank you.
Thank you, Dr. Anand. Because in the interest of time, we can have only one question from the audience. Thank you, Dr. Anand. If there are no questions, we can move on to the third talk.
Dr. Manjari?
Yes, we invite Dr. Ajit Sivadasan, who is a professor of neurology at CMC Vellore, and he joined there as faculty in 2010. After completing his DM neurology from there in CMC Vellore. He has a keen interest in neurocritical care and is going to talk to us about a problem which we face in our ICUs, where the patient is not getting weaned off and has a reflexia of critical illness, polyneuropathy.
Thank you, Dr. Manjari, for the kind introduction. So we go on to the next topic, that is a critical illness, polyneuropathy. So what are the neurological illnesses in ICU? So of course we have critical illness, polyneuropathy, critical illness, myopathy, encephalopathy, which has also recently been renamed as sepsis-associated brain dysfunction in ICU. And we also have disorders of neuromuscular junction transmission, which are usually related to pharmacotherapy like neuromuscular blockers. And there is a broad term for all this, that is ICU-associated weakness or neuromyopathy. And they cause common problems in the sense that they cause prolonged weaning from the ICU and increase the mobility and costs associated with the ICU stay. So, a short historical perspective, critical illness polyneuropathy was described as early as in 1977 to 81, where Charles Bolton actually identified there is distal axonal degeneration of motor sensory nerves on the biopsy and labeled the term CIP. Subsequently, somewhere around 96, in addition to a nerve damage, CIM, that is critical illness myopathy, was also identified, where direct muscle damage could vary in a spectrum to mild fiber atrophy to severe necrosis, even causing rhabdomyolysis. So that was the spectrum of critical illness myopathy, which was described mainly in patients who are receiving prolonged vecuronium as well as steroids. So what is common to critical illness is that there is a lot of systemic inflammatory response syndrome, SIRS is the catchword, and there are a lot of cytokines, chemokines, free radicals, which tend to directly target the axons, neuromuscular junction, muscle fibers, and because of a lot of free radicals, there is a lot of inflammatory damage. And sometimes, just like the Aman variant of GBS, they could be damaged mainly involving the terminal axons and neuromuscular junction, and at times very rapid recovery also. And sometimes SIRS could be due to infection, in which case it is known as sepsis, and can lead to secondary organ dysfunction and multi-organ failure, hypotension, etc. And along with it, you have a lot of oxidative stress and neuroendocrine dysfunction. Now, all these hormones are required for muscle anabolism. So, once the muscle catabolism occurs, there is loss of flesh leading to critical illness myoneuropathy. And of course, as already mentioned, electrolyte abnormalities like calcium, magnesium, potassium all need to be addressed in the setting of critical illness. So on this background, what is important to diagnose of critical illness myopathy and polyneuropathy is electrophysiology, because that's basically on a clinical setting, the electrophysiology is what helps us to make the diagnosis. So what is important in electrophysiology is you have to note at what time did you do the conduction and is there any serial conductions available. So some common patterns seen are, one is the loss of CMAP amplitudes with relative preservation of latency and velocity. SNAP, sensory nerve action potentials, could be difficult in critically ill patients because they tend to have pedal edema. So sometimes you have to do near nerve or subdermal stimulation. And whenever you put a needle, you can find spontaneous activity. Again, it could be as a result of denervation due to neuropathy, or even some case of muscle necrosis can have spontaneous activity due to muscle denervation. And some of the patients may be encephalopathic, so it will be difficult to recruit the MUPs also. And during the patterns of recovery, if you get small MUPs, it either indicates that it's a neuropathy which is reinnervating with nascent MUPs, or it could be just like myopathic potentials, which are small polyphasic potentials. And very commonly, you tend to have phrenic nerve involvement, which is a separate entity in itself. And with the help of advanced techniques like direct muscle stimulation, motor unit number estimation, or muscle punch biopsy, you can usually identify the cause of, establish the diagnosis of critical illness myoneuropathy. And it's very important to note that in contrast to patients with GBS, the axonal GBS not per se, a demyelinating picture is not seen on the nerve conduction studies. So what is defined as acquired weakness in the ICU? A patient develops generalized weakness after admission for critical illness, which is diffuse, symmetric, and flaccid, which spares the cranial nerves. And then you do a MRC scoring. MRC scoring, you usually have 3 sets of muscles in the upper limbs. That is the arm abduction, forearm flexion, wrist extension. This is hip flexion, knee extension, foot dorsiflexion. And the total score will be 12 into 5, that is 60. If a MRC sum score is less than 48 on at least 2 occasions more than 24 hours apart, the patient qualifies for a clinical definition of acquired weakness in ICU. And of course, these patients are likely to be ventilator dependent and the other coexisting causes of weakness need to be ruled out. A pre-existing illness needs to be ruled out. And then narrowing down to the definition of critical illness polyneuropathy, not ICU acquired weakness. In this, the patient should satisfy criteria for diagnosis of ICU acquired weakness. The CMAP should be less than 80% of the lower limit of normal in at least 2 nerves which are stimulated. SNAP similarly should be less than 80% of lower limit of normal in at least more than 2 nerves. And they should not have any demyelinating pattern. And your RNS also should be negative. So these are the criteria. And it is also important to realize that a high proportion of critical illness polyneuropathy patients actually have subclinical dysfunction. Your EMG may be abnormal, but the patients might have very mild weakness. And whenever a patient develops a flaccid weakness with a pre-existing loss of DTR, CIP comes into consideration. Cranial nerves are usually not involved. Similarly, fasciculations are not seen. If you find anything like cranial nerve involvement diffusely or fasciculations, etc., fasciculations could indicate that patient could have had a pre-existing neuromuscular disorder. And in severe cases, what is simple to note is that, like especially in the patient is encephalopathic, if you give a facial pinch, there will be a lack of limb movements to the facial pinch. So that's in encephalopathic patients especially. So these are slides taken from literature in which your routine nerve biopsy alone may not help. You have to go ahead with semi-thin sections to look for loss of myelinated fibers and severe loss of axons. Your routine H&E will help these fiber preparations again to denote the axonal loss, and Luxol blue to look at the myelin. So all these can help in diagnosing critical illness polyneuropathy. We go on to some interesting case scenarios. This is a 29-year-old lady who was admitted with a H1N1 infection with severe ARDS. She required ventilation for around 2 weeks, including prone ventilation for 4 days. And subsequently, after recovery, she was noted to have limb weakness involving the lower limbs more than upper limbs. The limb weakness was flaccid. She had an encephalopathy at presentation from which she had gradually improved. So the initial diagnosis was whether, okay, this patient could be having critical illness neuropathy because the setting for that was there with ARDS, ventilation, prolonged ICU stay. So this was the baseline conduction done at the time, that is 3rd week into hospitalization, which actually showed that all the CMAPs were reduced, but there's a disproportionate involvement of the lower limbs, peroneal, tibial, TAs compared to the upper limbs. And the phrenics were also very low. However, snaps were relatively preserved. And when this patient, when we saw in the 2nd or 3rd consult, we actually identified that there's something odd in this patient, why only the lower limbs are not moving, the upper limbs are relatively preserved, the snaps are well preserved. So it's 3rd week into illness. So this doesn't fit into a pattern of critical illness polyneuropathy per se. Is it a CIM or some other disease? At which time the reflexes also were flaccid. She was continuing to be on the catheter for the bladder retention. She was coming out of encephalopathy. At which time we actually did a MRI spine because she was not coming off the catheter and realized that actually she had multi-level cord signal changes. So this could have been part of an influenza infection because CSF also was abnormal. So this just to tell you that all patients with an ICU-acquired weakness need not be definitely characterized as a critical illness polyneuropathy or a myopathy. So similar such cases. So this is another 68-year-old lady who was admitted with in the medicine unit with a provisional diagnosis of an acute coronary syndrome with elevated cardiac enzymes with a LVEF of 35%, underwent medical management for the same and had improved. But for some reason they had difficulty in weaning off the ventilator even after 1 week in spite of optimal management of the cardiac problems. At which time we had a conduction done and found that the conductions was, apart from a disproportionate loss of the phrenic nerves, the rest of the conductions was reasonably preserved. There's a mild motor axonopathy per se. Similarly, snaps were normal. So this patient, we went back with the patient and asked for a pre-existing history of any neuromuscular disorder. We couldn't get it. And at which time we also repeated a RNS in the ICU, and it showed a significant decremental response from the nasalis and trapezius muscles. And we went ahead to proceed for a diagnosis with a suspicion of an underlying neuromuscular disorder. This patient had an AChR antibody which was positive, had a CT thorax which showed a thymoma. So it was actually a thymoma-associated late onset myasthenia gravis, and the patient actually had successful weaning after initiation of fibrostigmine and steroids. And she also had a concomitant thyroiditis, which is well known as presented earlier by Dr. Vinay. This will be another patient. This patient is different from our other 2 patients because this patient had a background history of 3 months of worsening respiratory distress, including orthopnea, recent onset orthopnea, and actually come to the emergency department and got admitted and subsequently intubated for a hypercapnic respiratory failure. And here again, the conduction overall is normal, but your phrenics are no response to stimulation. This was done on day 2 of admission. So this is a disproportionate pattern. Again, but the main points are the prior background suggestive of some underlying disorder and a disproportionate loss of phrenic amplitudes. So based on the workup, eventually because of diseases which can have more involvement of the diaphragm, we had gone ahead with an enzyme assay for alpha.
Only till seizure suppression, that is visible seizure suppression, the chance of recurrence of seizures is as high as 50%. But if you treat your patient till burst suppression, the chance of recurrence of status is as low as, is 4 to 8%. In your ICU, please tell your staff to send you mobile pictures of the seizures. If the continuous EEG is not available, Many things look like seizures and there can be over-treatment, so please ask them to use mobile phones. I ask my staff routinely to use mobile phones to document the events before we connect to the continuous EEG. With this, I'd like to conclude, and if there are any questions, I could answer them. Thank you
very much, Manjari, for